Thank you, Chair, and thank you for the opportunity to return to IVHEM. I was first here in 2017 when I spoke about the concept of microelimination, and now I'll be speaking about can we eliminate viral hepatitis in migrant populations in Europe, and I'll briefly touch upon the concept of microelimination in that context. So we're well aware of how much hepatitis B and how much hepatitis C is in the world. We know that B is largely in Asian and African countries, and C is largely in parts of Asia and across Europe, including Eastern Europe. What's important here is to note that some 3% of the global population in 2015 alone migrated from many of these countries to many of the high-income countries in North America and Europe. So we have a population migrating from countries with hepatitis B and C to European countries. That's what I'm going to address, particularly the unique challenge for host country health systems. The European Center for Disease Control ran a systematic review a few years ago. I won't go through it in detail, but let's take a look at the example of Spain on the bottom left. So you'll see the total population, the proportion that is foreign-born, but importantly, you'll see the proportion of foreign-born from hepatitis endemic countries, in this case, hepatitis B. So you see that around 4% of the Spanish population, or over 1 million people, are from countries where hepatitis B is endemic. So in a country like Spain, that's the population you largely have to target in order to eliminate hepatitis B. The next question would be which migrant populations? And on the right, you see some of the studies that informed that ECDC report. So you can start to get an idea of the prevalence. Although the sample sizes are quite small, you can start to get an idea of which countries are contributing to the hepatitis B burden in Spain. And indeed, in this ECDC report, you can see that for all of the European countries where data was available. Now, one thing is to understand which countries are the migrant populations that need to be addressed. The other is the barriers to care for these populations. So despite migrants from high endemic countries living in well-resourced host countries, testing and diagnosis are suboptimal. Health systems barriers limit effective testing and linkage to care for migrant populations. There are language barriers, cultural barriers, structural and legal barriers, a lack of knowledge and understanding both among the migrants, but also among many healthcare personnel dealing with the migrant populations. There are cost issues, transportation, and more. So the question at hand is, how can we effectively test and engage migrant populations in viral hepatitis care? Well, there are many solutions, and some of them have been discussed at this meeting. More generally, I'll highlight just a few of particular importance for migrant populations. One is point of care testing. That can be a rapid test like you see here on the far left. It can also be a dried blood spot. Here you see the new plasma separation card, which can run serological and molecular tests and can last for some 40 days at high temperatures, important in some parts of Europe and particularly important in some of the endemic countries that migrant populations come from. In the middle, you see the importance of culturally sensitive and accessible material. We need to make sure the language is accessible, but also that it's translated into the native language of the migrant population. The role of peer navigators is particularly important. Peer navigators are respected members of the migrant community. They may be religious leaders, they may be elders, they may be a medical doctor. Whoever it is, you have to identify who your peer navigators can be, because they will help provide access to that community and help you engage that community in the care, in the testing that is needed. And finally, there's particular importance of community-based interventions and community engagement. We can't impose a viral hepatitis program. We need to discuss it with the community and have them understand why it's important for them. And then we need to discuss on what terms such a program can be implemented. And this may mean, and I'll show you this in an example in a moment, that the services actually need to go to the community rather than asking the community to go to the services themselves, like hospitals and clinics. In general, one of the goals when engaging this population, and I would argue many marginalized populations, is the fewer the visits, the better. In order to test, we want to avoid a single or even multiple venous blood draws. We can use a dried blood spot, so we can have reflex testing, or we can use a rapid detection test right on the site, like with a DBS, but here we would get the results in maybe 15, 20 minutes, or even 5 minutes, like new data from the OraQuick study has shown us. The important issue to consider is how quickly can we move, but also where can we provide these tests and how can we limit the number of visits so it's as simple as possible for the population, for the migrant population that's a part of the particular study. Now, migrant populations will go to many different types of services, and here are some of them listed here. And in some of these services, there'll be a small percentage of the population, which will make it difficult to provide materials in their language or to engage with peer navigators. I'm going to focus on the bottom left here on community health centers, because if we go to a community health center for a particular migrant population, we know that the vast majority, if not all, of the people there are going to be from that particular population, whether they're from Ghana or Senegal or Russia or China or somewhere else. Let me share this example of a project we just launched in Barcelona, Spain. It's a community-based testing and vaccination initiative to link West African migrants to liver specialist care in the greater Barcelona area through the utilization of simplified diagnostic methods and peer supporters or peer navigators. So firstly, our research team at IS Global, the Barcelona Institute for Global Health, where I work, goes to the African community centers and provides an HPV awareness workshop. This is already developed in collaboration with the community and in particular with the peer navigator. After the workshop, we do a rapid point of care test and we collect blood samples or dried blood spot samples. We then return to the site to provide the results. Now, if they're positive, we're going to need to link them to liver specialist care for follow-up assessment. And we'll be doing that in collaboration with the peer navigator. If they're negative, we're able to assess with the DBS if they still need a vaccine or if they've actually been vaccinated. If they need a vaccine, we return with a nurse and we vaccinate them on site at the community center. And the peer navigator plays a role throughout the entire process, helping those who are positive maybe go back to primary care for a follow-up vaccination for their booster or to the hospital for treatment, but also answering questions when we're not there about viral hepatitis. Here are some images from the launch last week, and you see Camila Piccio, our coordinator, and Marcela Villota setting up in a Ghanaian community center in Barcelona. Here you see getting ready to start testing someone from the community. And then using a chair, we're drying the dried blood spots. They have to dry for 4 hours, but we are able to put them in plastic, transport them, and then have them continue to dry. And here you see the research team. Now, back in 2017, when I presented the EASL International Liver Foundation's concept of micro-elimination, we didn't think about including migrants in that population. So here you see the different populations that we prioritized, everyone from decompensated cirrhotics to patients with hemophilia, CKD, transplant patients, people who inject drugs. Some of those, of all of those populations, of course, will be migrants, but I would add particularly a new box here for migrant populations. And then within that migrant population, we need to further think about or break down microelimination to the particular migrant populations where there's a high prevalence of hepatitis B or C in the country or in the region. Ultimately, in order to know if we've eliminated or microeliminated hepatitis in a migrant population, we need to apply WHO's continuum of care or the consensus cascade of care, which has fewer points, and thus it's easier to collect all of the data and comparable data. And we need to apply this to each migrant population. So in our case with HPV comme ça va, that would mean looking at the Ghanaian population or the Senegalese population, estimating how many are in are infected, how many are tested, aware of their status, enrolled in care. I would add vaccination into this process, how many have been started on treatment if needed, retained on treatment, so on and so forth. This continuum of care is designed for hepatitis C, so we would adapt it for hepatitis B. Ultimately, I think we can eliminate viral hepatitis in migrant populations, but it will require understanding those populations, working closely with them, and making sure that we don't address migrants as one large population, like I'm doing in this presentation, but think about each, as we saw in the ECDC report, each of the populations that contributes to the prevalence in your particular setting. And let me acknowledge the full team, especially Camila from IS Global, who's coordinating the HPV Come Survive project, and Elisa Martreau, who provided our DBS training and is also working closely with us. Thank you very much.